Hi, good evening, Dr. Grigsby. How are you doing today?
Oh, doing fine.
Oh,
Life is good here in Napa.
that's so wonderful. So I want to thank everyone for joining us this evening, and those of you who couldn't join us in person, thank you for tuning in to the video recording. I know I'm very excited to speak with my guest tonight. I'm going to just quickly get started with a few disclaimers. Everything that we're talking about tonight, I am not an attorney. I'm speaking about purely based off of my experience supporting hundreds of practices across the country. And I don't know if you have any disclaimers. This is not a CME type of thing, but just any opportunity if you need to do that as well.
Are you asking me?
Yes.
I, I have no disclaimers except that I've made probably every mistake there is to be made in the medicine and the clinical practice and business side. So take my successes in balance.
Yes. And uh, just for those of you who do not know me, my name is Rachel Trobman. I'm the CEO and co-founder of Upside Health. I'm a digital health executive who has been working in this space for about a decade. I am passionate about pain innovation. I am also my research in the space of pain and in our application has been funded by the NIH. And a fun fact, I am a former news reporter and producer, so it's fun to have the opportunity to pull out my old skill set. And I am, as I mentioned before, thrilled to have Dr. Eric Grigsby joining me today. Dr. Grigsby is not only a world-renowned pain physician, but also the founder and CEO of Neurovations. Um, I also believe you're a wine enthusiast. Um, and I wonder, is there anything else that you want to describe yourself as? Were you formerly a reporter as well?
No, I'm just a curious guy that had a biological interest early on, and that transformed itself into medicine. And I also a career in medicine, and also have always had an interest in how things are built. In other words, why is it that people get together and do something of merit together? And how does that happen? And who has the idea? And what's leadership all about? And
Oh,
what
yeah.
are the common resources that are required to go from an idea to something? So I've had all of those curiosities and executed them in my own way, both in the healthcare business and outside of it.
And so let's talk more obviously, well, specifically tonight about your healthcare business. So you started a pain practice, Napa Pain Institute, um, a few decades ago, if I can say, and it has grown. And then you also started an enterprise, which houses Napa Pain Institute under it. But if you could talk a little bit about the various components of practice growth that you've seen. So obviously you have the lab, you have the research, you have the conferences, what order did they come about? And
Oh, good question. Yeah, thank you. Thanks for that. Thanks for the lead in. It's not like you've been a reporter in your former life, so I appreciate that, making these questions easy. I don't know the exact stage in career that most of the attendees are, but I'm going to assume that you're pretty early in your career, or you're just trying to sort this out. But if any of you are more advanced in your career and you have more specific kind of transactional operational questions, I'm happy to answer those in the chat, or however you want to go about it, Rachel, to get questions answered. But I'll tell you the brief kind of trajectory that I think most of us take, and just a brief story of mine, and see if it resonates with you or makes any sense. So I trained obviously in academics like most of us do, and I trained in general surgery for a couple of years at Mayo. Was very intent on becoming a general surgeon, and thank goodness I didn't, because the program was sort of in disarray. So I began looking for other opportunities, and the anesthesiologists that I knew seemed to be happy people, and they had a little extra time to do some things, and I thought that could be good given my sort of family ambitions. And and career ambitions, and I knew that I had some entrepreneurial enthusiasm. So I thought, well, a career in general surgery in a lot of ways would be limiting. So I trained in anesthesia and pain back at Mayo in the mid and late 80s, which was well before the specialty of anesthesiology gave birth to the specialty of pain management. But nevertheless, Mayo had a program, and so I began to understand it, and it was fascinating. And the thing that drew me to it the most was not the procedural piece, because we didn't really have many procedures. The thing that drew me to it the most were this group of patients that all came in with complaints of persistent pain, and who frankly were judged and considered to be, I mean, to be really fair, people just thought they were sort of crazy, lazy, or addicted, to be honest. But those of us that saw them repeatedly, saw these patients, knew that wasn't it, that there was something more to it. Yeah, there are lazy people and there are people with significant psychiatric illness. I get all that. But there were patients who had none of the above, but persistent pain. And so we knew there was some neurophysiologic piece, but it was completely uncharacterized back in those days, and it was thought to be some sort of behavioral thing. The idea of central sensitization had never been discussed. It wasn't known. Chronic fibromyalgia, myalgic encephalopathy, chronic fatigue syndrome were considered just kind of forms of laziness. And then on the therapeutic side, so we had no diagnostic tools. MRI was just coming around. CT was extremely slow and barely available. We had no fluoro in the exam room, so I don't know how many celiac blocks early in the day for cancer, without fluoro, just using a transaortic technique with the patient prone. So you put a needle in the aorta, you knew where that was. You put it just a little further and the blood stopped, so you knew you were near the celiac plexus, so you gave the medicine. So it was a pretty rudimentary practice, but we were all of us had entered in this field in the early days. First of all, we didn't have any tools to work with. We didn't really fully understand the pathology we were dealing with. And we took a pay cut to do it. So it was kind of a stalwart group of people who sort of began the specialty in the 80s and early 90s.
So you had a little bit of entrepreneur in you even before, just by choosing this career path, or this specialty.
Well, it definitely wasn't the straight path. The straight path would have been to stay at Mayo and start the program in pain. But family brought me to California, so I ended up in private practice. I started the UC Davis Pain Center. I still dabbled a little bit in academics for a couple of years, but then in 1992, I started the practice of pain. And as soon as we all opened the doors, all of us who had this experience back in the early 90s, as soon as you opened the door, you were overwhelmed with patients. But there were no codes, and the reimbursement was spotty, and there was no guidance on how you got reimbursed for these things. And so we had to create all of that in the very beginning, and also find a way to make a living. And so it wasn't clear what the practice was going to look like. Was it going to be heavily interventional? Was it going to be a multidisciplinary practice, which was the flavor of the day in those days? But we aimed our practice at, and I think this is a message for your entrepreneurial spirit, is we aimed our practice at what the patients needed. So patients came to us with chronic illness. So it didn't seem to make any sense to set up a practice that was organized to see the patient one time and do an injection and then say goodbye. So chronic illness needs to define itself in the operation of your practice as an entity that can see patients repeatedly over and over again, efficiently, and leave a margin. And back in those days, most people went into private practice and not into the university setting.
And so just to kind of double on that, from the beginning, the way that you set up your practice was as a business that was identifying a problem. Mm-hmm. And then you built the practice to particularly specialize to solve that problem from the huge inundation of patients you were seeing. So what types, is that what led to the other service add-ons or the other parts of the business? Or yeah, if you could talk a little bit.
Yeah, that's exactly it. So good question. So in business of any kind, you can't start a business because you want to sell something. right, right. It's a long uphill slog. If you have a warehouse full of Persian carpets and you say, well, I'm going to go into the business of selling Persian carpets, but there's no market for it. So, it started in business. It's not what do I want to do. It's what do I'll say customers. I don't mean any disrespect to our patients, but those people that need our services, you have to organize your business of any kind around what they need. And the first thing I did was the chronic nature of the chronic practice, take care of patients in the long run, not just looking to harvest injections. And the second thing I noticed very quickly was that I couldn't do 25 minor procedures at our local hospital in an 8-hour day because they're oriented towards more significant interventions. So the first thing we did was to leverage the existing business that we had to build a surgery center. So we built that soon after we organized the practice because that gave me control over an environment which I needed for the efficiency in order to do enough of the simple injections so I could spend the rest of the time in clinic seeing patients in consultation.
Question, in what size of the practice were you at when you felt like you were ready to have that surgery center? Could a single or a two provider or a provider and a mid-level, or do you think that you have to have more physician or more?
So the answer to your question is too early, probably. But the margins were a little different back then. I mean, the margins were better back then, to be fair. And by margin, I mean the difference between what you receive from a third-party payer and what it cost you to provide that service. So the margins were a little bigger, but I was in solo practice with one mid-level practitioner when I opened a surgery center, and it was a single OR, 3 exam room, 3 pre and post-op and exam room center, about 1,200 square feet. So it's a tiny place, but the purpose was efficiency, so that I could see enough patients to, fulfill the needs of the ratios that I became aware of that were clear, that you needed the ratio of new patients to follow-up visits to procedures became very predictable over a period of time.
Got it. And did you do that modeling yourself, or did you work with consultants to build what like the ideal pro forma was of number of patients, number of practice?
Right. Well, this was in the early 90s, so there were no consultants. so there was no Rachel back in those days to help us in the pain world understand, where the needs were on the part of patients and how we could satisfy that need and add a little margin. So I just did it myself. I mean, I have a background in economics and business and a little bit, although a background in economics as an undergraduate doesn't really help you for entrepreneurship. But I later went back to business school in mid-career, but it was after I'd already set the trajectory of my practice. So it didn't really help in the early days. So I just ran the numbers myself. It's just algebra. It's not overly complex.
Sorry.
Oh, no, it's all good.
So you're able to launch the surgery center with the aim of being able to, create more efficiency and better margins. Well, create better margins through more efficiency and being able to see more patients. What came next? Was it the lab or? Mm-hmm. I mean, I'm sure you were doing research throughout all this, and that's not so much of a business, but tell me.
Well, it has become one. But I think again, we just look for what the patients that we saw needed, and then we began to try to find some way to build that if we could, instead of that every business has a build or buy decision. And I'm again, if some of our participants are seasoned business people, I don't mean to go through basic business concepts, but there's always a decision like, do I want to buy something from a consultant, or do I want to build it myself? And I think that's relevant to you, Rachel, because a lot of us could go through the trouble of potentially doing remote patient monitoring and remote therapy monitoring, but for one practice to put the IT services in place and get the methods and the operation in place, to build it yourself is kind of a nuisance, and the margins don't support it. So there's some things that we haven't done in-house, and we've worked with organizations like you, and in other places we thought there was a big enough margin and it was within our wheelhouse to do it. So the next thing that we built in our practice was a clinical laboratory, urine drug screening laboratory. And again, the margins were a little bigger in the beginning when we looked at this, but we were outsourcing, hundreds of urine drug screens a month. And so that the reimbursement for those was very simple to understand. And we had this understood volume that we did every month. And so we just ran the number on gross income and said, okay, well, now what does it cost us to put a lab together? And naturally, you know, like everybody, you overestimate your income and you underestimate what it's going to cost you to run your business. But nevertheless, that was the next thing. Yeah. You're not familiar with that, I'm sure. Yeah, nobody is who ever started a business, but that was the next thing that we did was the urine drug screening laboratory, and that was, I would say very beneficial in the early 2000s, early mid 2000s to us, added some margin so we could continue to grow in other areas.
And you've expanded upon that, correct?
Well, we expanded the lab. I mean, the lab, once you have a CLIA certified lab, and we have both a reference laboratory. Those of you that know the lab business, you understand that most labs that in our world are physician office labs, and they're credentialed under a slightly different pathway, but you can only do samples from your own practice. So if we want to take care of samples from other practices, other clinicians, you have to have what's called a reference laboratory, which has a whole different set of credentialing and licensure and so on. So we have both. But having the lab did was during COVID, we were asked by Napa County, where I live, to do all the COVID testing for Napa County. So again, it's kind of looking for an opportunity. So we did 100,000 COVID tests, and that kind of kept the schools and sports teams and businesses open in our county during COVID, which was an unexpected opportunity. But again, people say, well, that was just good luck, wasn't it? Well, the old story that, luck is, preparation meets opportunity, so there's always, entrepreneurs, I think, are always looking for opportunity and looking at the resources that you have and seeing how you can apply it to a new challenge.
So to recap, so far we've got a interventional pain clinic, we've got a surgery center, and then we moved into a laboratory, all to help kind of support each other. Now, the research component, the Medtronic's, Boston Scientific's, Nevro's, whatever of the world. How do practices start building that capacity or that infrastructure? As I know that that's a growing area of interest.
Well, thanks. Yeah, it is for me, and just in general, my business has sort of flipped in the last 5 years from a clinic that does a little bit of research to a research and innovation business that happens to own a clinic. That's sort of how, my career has gone. But clinical research is an interesting part. It can be an interesting part of medicine, of the practice of medicine. I was trained in research at Mayo, so I had some understanding of clinical research, but I had no idea how to do it myself, because Mayo has more administrators and clerical administrative people than it does doctors. So there was somebody to help you at every corner. But research usually starts by being a really busy clinician. This is the typical situation: a really busy clinician and someone who has a medical device or a drug or a minimally invasive procedure sees that your volume is high and they have a need to get additional data on some existing product or a drug. And they know that you're a busy practitioner, you have a lot of those cases, and that you're an ethical person, and they will do their due diligence to see if you have a reasonably organized administrative function in your practice. And they will ask you to get involved in a basic study, in an easy study, what I would call an easy study. And that is a drug or a device that's already in the marketplace. It's already FDA approved. It's already being sold by the company, but they want a little bit of additional data, let's say, to get the drug approved instead of just for depression, to get it approved for pain, let's say. And so they will ask you to enroll some patients and so on. And most practices get started that way, even in the institutional practice, get started that way by a busy practitioner being approached by an industry sponsor.
Can I ask a quick follow-up question? So you said a moderately organized administrative function or something. Can you just clarify, is there specific personnel that you would want to have in place before being able to support something like this?
Yes. Well, maybe I can briefly tell you the process of clinical research. So the process of clinical research is that, well, 80% of dollars spent on clinical research, clinical development in the United States are from industry. So we have an NIH funding here, but the academic piece, NIH funding, DOD, DARPA, funding.
Sorry. I'm familiar with I meant internally within your organization.
Right.
Are you looking for more, being able to select candidates internally? Would you be able to utilize MAs, or are you hiring specific?
Well, first of all, I appreciate the question, but first of all, you need to understand what the tasks are that are required. So one is the company is going to send you a contract for your services. So you need to understand, how do you read a contract? Can you do that yourself? Probably you can. You can send it to a healthcare lawyer for a minimal amount of money, make sure there's no dumb things in there. Then there's a budget that they will send you. So you have to have somebody, if you don't have the facility to understand the budget, it's not complex, but there are nuances to it. So you need a bookkeeper, somebody with some Excel familiarity and can understand the protocol, and then how the budget might apply to that, and how much energy you're going to have to put into each of those services. And then you need someone to help you execute the trial. And those people are called clinical research coordinators. And that's a little bit of a loose designation in a way. There are two organizations that certify clinical research coordinators to help you in the clinic. Most physicians, when you start out, though, use somebody on your staff. You use a MA, or which I think is the direction you were heading. They use an MA or an RN who happens to be on your staff and who is organized and administratively capable, and they are really sort of trained by the sponsor, and they can kind of get you through a basic trial. Your first iteration of collecting data, and the level of compulsiveness that's needed for clinical trial data collection is far greater than the level of compulsiveness needed for clinical medicine. I know that sounds crazy, but it is just the truth. The dates have to be a certain way, T's crossed a certain way, I's dotted a certain way. The timing is exquisitely important, et cetera. So you have to have somebody super compulsive, and that's the way most people get started.
And so, no, thank you for that clarification. And so what I'm wondering, in terms of practice readiness to be able to move then, so you have to have enough stability within your practice and enough volume that you're obviously attracting the attention of industry, and then having enough key personnel in place that it's not going to fully disrupt business when you're deploying.
Right.
This. And then to move to the next level, I mean, you took it, obviously built a whole research arm.
Mm-hmm.
And obviously that changed in terms of a dynamic and a structure. Why?
Why do it? Or
yeah, just like, what is, I'm like losing my.
I can tell you why. I'll go ahead and tell you why while you think about the follow-up question. Yeah. The why is because you think it'll be fun, and you think it'll make you some money.
Yeah.
I mean, that's why you do everything. That's why every entrepreneurial thing is done. And by fun, I mean provide service, have some greater good to society. And those are the fun parts. Mm-hmm. And then you think it'll be profitable, because in the healthcare service world, most of us don't operate in a nonprofit setting or in a truly community service setting. Some of my colleagues do, but in pain, almost never. Federally funded primary care practices are a different breed of cat. We work with them closely in town, especially on cancer and terminal illness and various things. But pain practices generally are in an institutional or for-profit setting. So you have to make a living doing it, and you want it to be interesting and fun and have some spinoffs, to help the brand of your practice and to help you understand things. And if you really want to take it further, then it introduces you to some ideas, to have an avenue to express some of your ideas about how things might be better for your patients.
So, and I think that's interesting when you reach that level, right? It's not as much of just the opportunities coming to you, but then it starts becoming a business, right? I'm assuming, like, putting and building the brand of yourselves as a research institution, and being able to respond to RFPs, or maybe if not in your institution, but in others, right? Being able to be both proactive and reactive to opportunities. Is that where, and your love of innovation, is that where the conferences came from, or was that business line separate?
It was separate. So thank you for bringing up the meeting. So this year we had our 30th Napa Pain meeting, and that started in the early 90s. And we have a Kauai meeting in past years, and we have another science meeting, a neuromodulation meeting. We do a bunch of webinars and various things. We have a cadaver lab here and things of that sort. But that started early in the going because in the early 90s, there wasn't a pain meeting west of the Mississippi River in the calendar year. So we thought, well, it'd be really handy to get a few of us together who were trying to figure this out, both clinically and business-wise. And so the meeting was just out of the need of a bunch of my colleagues and myself to get together and talk about things. And then it became a place where the industry sponsors, and this is a long story you may not want to go into tonight, but the neuromodulation industry went from zero essentially in 1988 when I finished my training to, a $2 billion business worldwide now. And that drove the meeting business for a long time. And all of the societies and in our field and all of the meetings of any size were funded by neuromodulation and minimally invasive spine companies. It turns out that the neuromodulation growth industry is flat today, very, very flat. And so sponsorship from those companies for meetings is slowed down a lot. But that's a different topic. That's just the nature of it. But again,
we'll do 2.0.
Do 2.0 on the neuromodulation industry.
On the neuromodulation industry.
Perfect.
If we still have people. If you liked our can-do talk and you liked our talk about practice growth, you're gonna love us on neuromodulation. So then so a lot of these things you've built have been, are vast. They're very impressive. But I feel like there's some small things that you and I have spoken about that you've done in your practices that may be more approachable, or you could start tomorrow or next week, that don't require fully reformatting, that can have a dramatic impact. Maybe not. Are there any things that come to mind, or where you feel like even small practices can start by creating growth?
Well, yes. I mean, but before, you look at the specific things, the first place you have to go is, what do my patients need? How could my patients be better by something I can provide them? That's first question. And that should be going through your mind more or less every day, is what is it that we're missing here? Would it be helpful for me to understand my patient's pain level daily? Would it be helpful to understand their compliance with my medication regimen daily, weekly, monthly? Would it be helpful? And what's going to lead to a better outcome for my patients? Question number one. And question number two is, can I afford to do it? Can I make a living doing it? And can I enhance my living, my ability to be economically, financially successful by doing that thing? And number one, if you satisfy question number one, it is not always, in fact, I'd say rarely, supported by number two. There are a million things I could think of that my patients, they could be great for my patients. If my patients, the one I saw today, multiply comorbid, lives on the margins of society, had a really, really challenging life, all kind of psychological comorbidities, really an amazing bit of resilience on her part to be functioning at age 60 with all the stuff she's been through, incredible life. If I could walk around with her all day long and make sure she stayed out of trouble and took her medicines at the right time, that would really lead to an improvement in her life. Well, that's just not economically advantageous to my practice. So there are things that would lead to improvement, but you can't do. But when they converge, then that's where the fun is, right? That's where the fun is. And I believe that's what your company is trying to achieve, which is to have a convergence of more information about our patients on a daily, weekly, monthly, on a regular basis that's communicated to the practice that also is reimbursed. And so we get a little bit of extra money for providing a service that leads to the better outcome for our patients. And that's sort of the, the holy grail as it is. I mean, that's really where the convergence of the need and the financial viability live. And there are a few of those places even yet today.
In regards to revenue cycle management, taking things in-house versus outsourcing, have you found any strategies in place, like reasons why you chose one way or another? Were you doing it in-house from the beginning, or is that something that you built over time?
I've never spent a day having anybody collect my money except my employees. And the reason is not because I'm worried about illegalities or nefarious activity on the part of a billing team. The problem is it takes it out of your consciousness. So you don't pay attention unless it's in-house. You have better access to information. You should be asking questions constantly, whether you're in an institutional practice or not. If you're in a university or institutional practice, you should be that one who's kind of driving the administration crazy by wanting to see your production numbers. They may not give you the dollar production numbers, but it would be great if they would. But you want to see how many patients you're seeing and what kind of services are we providing as a group. And so if you outsource that, you will not have that information as readily. It's too easy to ignore. And I would highly recommend, if you're in a private independent practice or a small group practice independently, that you keep the money close to you.
And because it does, especially given, continually changing insurance requirements, continually changing payments and documentation, I think there is some challenges with taking that, in-house and having the skill set of the people who are really comfortable and familiar with that. Is there training programs or resources that you rely on to keep you and your team up to date so that you don't fall behind, because the difference in being aware of what the new requirement is before a procedure or whatnot can really be a big difference between whether or not you're going to get a denial the first time or not?
Yeah, so the answer is yes. I mean, the answer is yes, but there are good consultants available now. I mean, it's not a mystery today, and what the ambulatory surgery center reimbursement is. There are trade groups and sort of free information, and then there's subscription information from ambulatory surgery center and medical practice groups, and even there's a Society for Pain Practice Management, you may know, ACIP and the state societies for interventional pain practice, do a really good job of helping provide resources and advocacy for coding and reimbursement issues that relate to the interventional pain practice. So there are a lot of resources available that weren't when we started in the early days, and we just sort of had to figure it out. But yes, there are resources, but I think what it gets to, and I want to, I guess, just make this point, that entrepreneurship requires you to love building things, because the work of building it is substantial. And so if you don't love reading a financial spreadsheet and motivating people and providing leadership and shedding a little bit of the physician ego, like everybody should be serving me, if you don't love that, it's very difficult to be in an entrepreneurial environment, especially solopreneurship. Like if just one or two of you and you're trying to make it work, somebody has to love it, because on average I spent probably 30% of my professional time building the business, building the infrastructure and getting the people and understanding all these questions that we just brought up. And it's tremendously satisfying. I mean, it's unbelievably satisfying. And I'm for sure money ahead compared to, if I'd been in an institutional practice and had a 401k as my main investment and, made a good living. I'm for sure money ahead, but it's not easy money. And it requires a little bit of a skill set that you'd want to challenge yourself to understand about how to set a goal, how to lead people and resources towards that goal so that you get what you want. And kind of like tennis, I don't know, I play a lot of tennis, maybe some of you do too, but you're you're successful about 51% of the time on the business side. You hope you are, right? You don't have to be successful every time. So you have failure. So, or like, hitting a baseball. If you hit a baseball 1 out of 3 times, you get a $20 million a year contract. Business is not quite that bleak, but you will make mistakes. And so you have to have the constitution and the confidence and the ability to weather that. But it is tremendously satisfying, but I would say that it's more than just a little add-on to clinical practice. It has to be something that you enjoy professionally enough to commit a chunk of your professional energy and time to build other things around your practice. I just want to be realistic about that.
No, and I really appreciate that. And I want to make sure that we have at least 5 minutes for questions should they have there. But I want to throw one more question out there, and it's more about marketing and advertising. Because marketing and advertising your practice is not necessarily building different business lines. It's just trying to, promote and grow and differentiate potentially. In terms of where you found successes or challenges doing that, I know that you have some of that in-house, but in the early days, was it always in-house? Was that just you becoming, a key opinion leader on those kinds of things? Was it you versus the practice? I'm always interested in where people see success.
Well, thank you for asking that. So there are 2 different marketing needs that you have when you start your practice. The best marketing that you can ever create is to take good care of the patients that are referred to you. I mean, exceptional care. Go the extra mile and communicate with the referring doctor. I would just ask you guys to all think, like, do you say thank you for every new referral that comes in your practice in some way to the person who referred them? For a bunch of years, I sent out a little card. I'll show you the card.
Of course, you still have
I just happened to pull one out today, but I had these silly little cards, and I had these attached to the chart, the paper charts in the early days, and still they get attached to the little bit of information. And while I was with the patient in the exam room, I said, "Dear Dr. Smith, thanks for asking me to see Mrs. So-and-so," or this patient, if you don't want to put the name in the analog format. And I say, she has a low back pain and radiculopathy. We treat a lot of that. We have all the interventional pieces. Thanks a lot. Give me a call. Here's my cell phone. Thanks. So doing great work and saying thank you to your colleagues for confidence in you and carrying yourself like a professional is the very best marketing you can do for a long time. And once you get a business that benefits from broader, I'll say, non-personal marketing, that's a stage of life that I didn't get to for 20 years, really. And until then, I just tried to let everybody that came in contact with me know that I've got time for them. You're going crazy. You're doing 15 things, raising 3 kids, taking care of family, building a business, taking care of 25 patients a day. And you're exhausted, and somebody calls you and says, "Hey, Eric, I got this patient in the hospital and they're really tough. And they describe this impossible patient to you. They say, would you mind seeing them today? Because, I'm going on vacation tomorrow and my team." And there's 2 ways to answer that question. "John, I'm sick and tired of you dumping these patients on me." Well, okay, you can say that. You get to say that one time, but you better make sure it's really worth it, because John's not going to send you patients anymore. The second option is you can get a grip on yourself and say, "Hey, John, thanks a lot. I really appreciate you calling. As soon as I'm done today, I'll go see him. No problem. Call home, honey. I got to take care of this because it's going to take me a minute, but I'll be home. And can I get anything from the store on the way?" That's the very best marketing you can do for a long time.
Well, thank you for your wisdom and I love the stories. I just want to open up if anyone has any questions, specifically for Dr. Grigsby about growth or about to me. I mean, I'm happy to talk with anyone who's on here offline about, how remote care and remote services and digital health can help support practice growth. But if no questions, also, I want everyone to have a nice evening or afternoon. Give it one more question and one more moment if there's anything coming through. I know we've covered quite a bit in this evening. All right, we've got a question. Okay. What I don't know, Margaret, Dr. Bolta, I don't know. Let me see if I can allow you to talk. Why don't you should be able to ask a question now.
Okay, well, I was going to type it, but thank you very much for your experience. And I'm actually a neurologist and did general neurology for several years and got kind of sort of burned out. And I ended up moving into the interventional pain world a couple of years ago and got boarded. I'm actually doing a pain fellowship at age 54 right now for 1 year, which I'm loving. I love everything about interventional procedures and both ultrasound and fluoro. But anyway, so I'll be finishing fellowship and I'm starting my practice in Macon, Georgia next summer.
Right.
But I'm working on my business pro forma now, and it's very hard to predict, in my opinion, how to figure out what the revenue is going to be or how many which patients are going to get injections. I'm going sort of by what collections I did before I started the fellowship, seeing so many patients a day, but it's still, that was maybe 2 or 3 new patients a day and a total of like 20. I'm having a very hard time knowing how I'm going to start. There's going to be competition. Yeah. I'll be the only female neurologist doing interventional pain. There's plenty of competition there. But so I'm just trying to figure out how to predict that.
Well, it's a good question, Margaret. Can I give you a little bit of one key to the kingdom?
Yes. I've got my pen.
So one thing you'll have to do is to figure out at steady state, what would you want your practice to look like when it's mature? And I can tell you that in our world, each physician sees 400 total patient touches per month.
Okay.
This is just kind of where the rubber meets the road. There's no extra charge for this consulting.
400 total encounters.
400 total touches. And that's divided to be approximately 30 new patients per month.
30 new per month. Okay.
About 100 fluoro-guided injections, minimally invasive procedures, epidural injections, and so on.
Okay.
About 10 surgical procedures, spinal cord stimulation, peripheral nerve stimulation trials, pump placements, neurostim placements. Gotcha. About 10 of those kinds of, again, this is steady state. This is not your first day in practice.
Of course. Of course, definitely not.
And then about 260 follow-ups. All right. And I leave an hour for new patients and I see a follow-up halfway through. So when the patient gets into a gown, I go see a follow-up and then go back and see them. But that's a one full-time physician practice without a mid-level practitioner. And I would plan on getting there, Margaret, before you consider hiring a mid-level practitioner. It'll be a lot of work because you got to take all the phone calls.
Right.
But otherwise, you're going to be spending a couple $100,000 a year with benefits, for somebody to grow with you. And I don't know what your personal financial situation is, but that's a lot to spend just to have company.
Right. Exactly.
And then you can go to the average the Medicare reimbursement for those services, consultation, follow-ups, and all the injections, and the surgeries is well known. You can get at that on the internet, and you can say, well, what is that going to generate in gross income? And then you can say, well, that's going to take about minimum of 65% overhead if you have your billing in-house.
Mm-hmm.
And then you can say it's going to take me 9 months to ramp that up, and you can build a pretty fair little business plan just with that information.
That's very helpful. 65% initially, and that's with a billing person that you have to hire yourself that has some experience with.
Right. And don't skimp on that person, because when you hire an expensive person in the beginning for your billing and collections, and that person will likely turn into your business manager, to your office manager.
Gotcha.
Spend the money on the billing collections person in the very beginning, and then have an eye towards them becoming your practice manager. And then he can bring in someone to train to, take over the billing with a little bit of supervision at a later time. You don't need an RN. Don't hire an RN. Please don't hire an RN. Just hire a medical assistant. And he or she can answer the phones, and then you have a billing person, and keep it lean in the beginning, super lean.
Gotcha. Well, I'm not going to be doing a surgery center this time, initially. In Georgia, all the pain doctors have their own surgery center. Apparently it's not that hard to get a certificate of need. And but there's no multi-specialty one around. So I've got to figure out where I'm going to do my,
Well, you can do it. You could do it in office for a while. If you, I don't know, just do an in-office fluoro suite for a while.
Yes. Yeah. I'm definitely planning on doing that.
Then you don't need a solution.
Oh, sorry. I dropped in the chat in case you don't have it handy. CMS puts together a very handy physician fee schedule search. So if you're trying to work on the pricing, you can just drop in all of the codes for the various procedures.
Oh yeah, I've done those. Yeah.
Okay.
Because you have to go through your particular zip code and that kind of thing. And
good.
So.
Yeah.
Well, and I've got my reimbursement from the last when I was actually working my collections, but.
Well, you're at the start of a very interesting adventure, and I know you'll do well. Just keep asking good questions and be willing to work hard. It's just going to take a minute to get all this figured out, but have fun doing it, and just treasure the opportunity and congratulations, mid-career, to have the courage and the enthusiasm to make a big change in your direction. That's awesome.
And thank you so much for sharing your question. I'm sorry, we're going to cut it out a little bit so that way we can wrap this up and put together something easy for others to listen and learn from. Thank you again, Dr. Grigsby, for your time. And if anyone has, again, any questions for myself or anything super pressing for Dr. Grigsby, I'm sure I could get it into his hands, as I'm very persuasive. You can feel free to send me an email at rachel@upside.health. It's in the chat box. And I wish you all a really wonderful evening, afternoon, wherever time zone you're on, morning if you're coming to us from somewhere across the globe, and we'll be in touch soon.
Okay. Thank you, Rachel.
All right, take care.
Thanks, everyone. Good luck to Rachel. Good luck to you, and Margaret. Good luck to you too, and all the rest.